All right, if you're gearing up for your anesthesia finals, you know that the Airway Toolkit is, well, it's everything. So let's cut right to it. We're going to do a fast, high-yield tour of the Airway Trolley, focusing on exactly what you need to know to nail those exam questions. Here's how we're going to break it down. First, we'll cover the absolute fundamentals, the stuff you need just to keep the patient oxygenated. Then, we'll get into visualizing the larynx, securing the airway with a tracheal tube, and then we'll look at the alternatives, like supraglottic airways. And finally, we'll wrap up with the rescue gear for when things get complicated. Okay, let's get right into it. Every single airway plan, and I mean every single one, no matter how complicated, starts with these foundational tools. Getting these right is absolutely non-negotiable. Think of these as your first responders. You've got the face mask, right? That's your main way of delivering oxygen. But what if the tongue is falling back and blocking everything? Well, that's where your adjuncts come in. You've got the nasopharyngeal airway, which is a soft tube that goes through the nose, and the oropharyngeal airway, which you'll often hear called a guttle, a rigid piece that goes in the mouth to physically hold the tongue out of the way. Okay, basics are covered. Now for the next critical step, actually seeing the larynx. This is your gateway for placing a tracheal tube, and there are basically two different philosophies on how to get that view.
So this is a total classic for your exams, and it really comes down to one simple question. How are you seeing the vocal cords? Are you looking directly with your own eyes, or are you using a camera to do the looking for you?
And here is that fundamental difference. With direct laryngoscopy, you literally have to create a straight line of sight from your eyeball, past the tongue, all the way down to the glottis. You're physically moving things out of the way. But with video laryngoscopy, it's a whole different ballgame. A tiny camera on the blade tip sends the picture to a screen, bringing the view to you. It can be an absolute lifesaver in a difficult airway. And this brings up a super important point. Not all video laryngoscopes are the same. You've got your standard Macintosh-style blades, which feel familiar. Then you have hyperangulated blades, which are designed to literally see around corners in tricky airways. And some even have a channel, which is basically a built-in guide to help steer the tube right where it needs to go. So, you've used your laryngoscope, you've got that perfect view of the larynx. What's next? Well, now you've got to secure it. And for that, we turn to the absolute workhorse of airway management, the tracheal tube. You have got to know the parts of this thing for your exam. I mean, really know them. You've got the bevel at the tip to make insertion easier, that little Murphy's eye on the side, that's your safety net in case the main opening gets blocked, the cuff that inflates to create a seal, and of course, the universal 15mm connector that hooks up to the circuit. Okay, file this one away because it's a classic exam pearl. Ever wondered why the bevel face is left? It's not random. It's designed that way specifically to improve your view. As you're advancing the tube through the cords, the opening is pointed away, giving you the clearest possible line of sight. It's a simple little detail, but it's brilliant. But of course, it's never that simple, is it? One size definitely doesn't fit all. There are a bunch of specialized tubes out there, each one designed to solve a very specific problem in surgery. This table right here, this is pure gold for your revision. Your whole job is to link the feature to the why. For instance, you see that spiral wire and the reinforced tube? That's there so it won't kink when the patient's head is turned. The microlaryngoscopy tube is super narrow and long to give surgeons more room to work. And the RAE tubes have that built-in curve to keep the whole breathing circuit out of the surgeon's way during facial surgery. Okay, so what if intubation isn't the main goal? Or what if you need a really solid backup plan, a plan B? Well, that's where Supraglottic Airway Devices, or SADs, come in. Just like the name says, these things sit above the glottis. They don't pass through the vocal cords. Instead, they create a seal around the top of the larynx. And they come in different styles. Some, like a classic LMA, have an inflatable cuff you fill with air. Others, like the eye gel you see there, use this really cool thermoplastic gel that molds to the airway as it warms up. For your exam, this is a big one, the difference between first and second generation devices. And honestly, the absolute game changer for second-gen SADs is the gastric drainage channel. It's a separate tube that allows any stomach contents that come up to bypass the airway completely. It's a huge, huge safety improvement against aspiration. All right, last section. Let's talk about the tools that help you out when things get a little tricky. These are the aids that help you guide that tracheal tube right where it needs to go, especially when the view isn't perfect. The Bougie. Seriously, this thing can be your best friend when you have a bad view of the larynx. The magic here is all in the feel. As you pass that angled tip through the cords, you can often feel a series of clicks, like a washboard, as it bounces over the tracheal rings. That feeling is your confirmation. It tells you you're in the right spot, even if you can't see it clearly. Now, a stylet does a totally different job. It's not about feeling your way in. It's all about shaping the tube before you even start. It's basically a bendable wire that you put inside the tracheal tube, and it lets you create that classic hockey stick curve. This is absolutely essential for aiming the tube towards the glottis when you're using one of those hyperangulated video laryngoscopies.
So, what's the big takeaways from all this? It's pretty simple, really. Knowing your equipment isn't just about memorizing facts for an exam. Your airway plan is your equipment plan. The two are completely intertwined. A deep knowledge of these tools is what lets you build a safe, effective, and flexible plan for any situation.
And as we wrap up, I just want to leave you with this question. Stop just memorizing what a device is. Start asking, what clinical problem was this thing designed to solve? As soon as you start thinking that way, your ability to create truly robust and safe airway plans is going to grow exponentially. And just so you know, this entire explanation was based on the fantastic review article, Equipment for Airway Management by Carton and Lyons from 2024. Good luck with your studies.